was showing neurologic deficits, vestibular signs, lethargy, depression, and like focal twitching and seizures, and had no external signs. We're waking up. No external signs of otitis externa. And then when they finally did an MRI looking for a neurological or structural cause of the seizure activity, they found the issues with the right tympanic bulla. Can I get all the other equipment, please, starting with the Gelpies? And so the MRI showed a cholesteatoma in the right bulla. And so we are doing a total ear canal ablation to resolve that. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. All right, so this is Huxley, right? Yes. And Huxley is about an, I think, 8-year-old? 4-year-old? Yeah. 4-year-old Old English Sheepdog. And so a little bit of an unusual breed to be doing a total ear canal ablation on. Can I please get one of my pointy tips for my cautery? Yeah. Thanks. So when we do this approach to the total ear canal ablation, we do have to often cut through the parotid salivary gland. I'm also going to need another Metzenbaum scissor. Those are dull. Please, thank you. The nice thing about not having any evidence of otitis externa means that hopefully the dissection is going to be easier. Is that the little needle tip? Hold on just a second. Oh, before you take that, let me just make sure that that is what yep. And I won't need that yet. So we're getting close to parotid salivary. Hello from Ohio. Glad it's your favorite surgery to watch. Full disclosure, it's not my favorite surgery to do. I do a lot of them, but I find them quite fiddly. Much rather do a spinal, given the opportunity. I don't mind them. And I certainly prefer them in a long-nosed dog than in like a Frenchie. So we make the vertical part of the incision over the vertical canal, and then try to flip that inside out for me, please. Yep. hardest part of the surgery is getting that initial plane of dissection around the ear canal. You okay up front?
Yeah, just like ACG. Like this kind of somewhere.
And we try to take out that I think it's called the tragus, that right there. Just makes it easier to close. I apologize in advance, I may be shaking a little bit because I've taken Sudafed for my allergies.
Does that make you shaky?
It does make me a little bit shaky. Bet you wouldn't have even noticed if I hadn't said anything. Should have just kept my mouth shut. And you see how much help having a good assistant is. So Cindy is constantly pulling the tissue apart because cutting the tissue is so much easier when it's under a little bit of tension. This way here. So getting this first initial plane of dissection is that first hurdle. Once you get that plane of dissection all the way around, it gets a lot easier. Just like that. Okay, so we'll just look around here. Have a look at what I've got and what I've done. Make sure you guys can see what I'm doing. Pull that up like that. And we're confident that the plate is very wet. Maybe just wet it just a little bit more if we could. Feels like the cautery isn't working quite as well as it might be. All right, so now I'm going to switch over to my needle probe. Needle probe concentrates the electric cautery a little bit better. Also allows me to get up underneath some tissue planes.
Yeah.
It's a little bit more delicate as well. Is that soaked?
Yeah.
Thank you. And the key with this surgery, again, in avoiding facial nerve palsy, is to stay right on the auricular cartilage. Is that working? No, it's not working at all. I'll just pull that back and let's see. All right, so now I'm going to bend the tip of the cautery probe into a little angle. Just makes it a little easier to dissect. Let's see what I've done there. It's a little...
Show people the curve.
What's that?
No, just gotta show people how curved it is.
And what that allows me to do is just be a little bit more precise with what I'm cauterizing through. So I can hook it first and then activate the cautery. So get underneath it first and then activate. See if you're getting suction at the tube. Yeah, so is it all the way on at the wall?
Yeah, it looks like it.
And I usually try to get away from using cautery when I get to the horizontal ear canal. So just go just a little bit further. And I'm switching to sharp dissection at that point to avoid damaging the facial nerve. Okay. Now, can I get a new Metzenbaum?
Yeah,
Oh,
this is a
thank you. Did we hand off the other one?
The old one is here.
Let's just hand that off to get that sharpened. Thank you.
Do you want to clean it and then put it in the sharpening box?
Yeah.
So I'm being really, really careful down here because caudal to the ear canal is where the facial nerve exits the stylomastoid foramen. We also have to be careful with our retraction to make sure that we're not putting too much tension on the facial nerve either, or on the tissue surrounding the facial nerve.
Yep, I can feel that now.
So just staying right on that auricular cartilage. Can we get some tiny rat tooths? Some little brown Adsons, or little Adsons? Just pull that right forward, please. This is definitely the most important part of the surgery. It's when we start getting down close to the skull, making sure that we're getting all the soft tissue off the cartilage so that we don't damage the facial nerve. What do you have there? Great, thank you. Beautiful. So you can say I've got some really delicate little rat tooth forceps there. I'm down to the skull, right here. So I can feel the bulla. And this is the critical part here to avoid that facial nerve. So I'm down to the skull. Just pull that up for me just a little bit. So I'm down to the dorsal aspect of the auditory meatus. So that's the tympanic bulla right there. So we've amputated that ear canal now. I'll just have a look down here and see if I can see my facial nerve. Cannot see it. That's good. All right, so the next thing I do is just expose the ventral part of the bulla a little bit. That bulla is very thickened. Alright, so the facial nerve is, oh, there it is right there. So there's a big branch of the facial nerve there. Another one right there. And that bulla, I wish you guys could see it a little better. Just see, you guys can kind of see it. So now I'll just chip away at the ventral aspect of the bulla. Can we get a culturette, please? You can hear me crunching away. Just going to see if I can move this across so you can see from the other direction. So I'll try to keep my head out of the way. Can you guys see down there? That is one gnarly looking bulla. Alright, so I'm just going to stick the culturette in there. And I'm trying to be careful not to get it to start bleeding. Yes, I am. Thank you.
question about what is the name of the elevator you are using?
It's called a Freer elevator. This one right here, spelled F-R-E-E-R. And we have them in all of our soft tissue kits because they really are an excellent dissection device. This Bulla is just disgusting. All right, get ready, guys. That is just horrendous and very exciting at the same time.
Yeah.
See if I can get it out with a hemostat. Look at all this stuff coming out of there. That is so gross. And appealing. Yep. So I am able to see the glistening inside of the Bulla. No wonder this dog would be uncomfortable. Look at that. It's a small alien in this dog's Bulla. I was debating whether I was going to live stream this because I have so many of them already up on the channel, but it seems like people still like watching it.
Yeah, especially this one is pretty unusual.
Yeah,
Oh wow.
look at that, all that lining. So if you like watching repeat surgeries that I already have a lot of on the live stream YouTube channel, can you let me know? Because often I think that people would be bored watching the same things over and over again. But if you don't think you'd be bored and you're happy to watch the same things, let me know.
I've got a question about how do you know that you removed enough part of Bulla?
So the amount of Bulla that you have to remove is just whatever it takes to get a really good look in there. And you have to make sure that you can see the whole Bulla so that you can get all the soft tissue out, because if you leave any soft tissue out, you're going to get recurrent abscessation and draining tracts.
Triage to resection, triage to resection.
You got a comment about we come for the surgery and stay for your humor.
Tell my nurses that I'm funny, because they don't believe me. I tell them all the time. I assure them that I'm very funny,
Yes?
but they just don't believe it. What, my head's in the way? Thanks. Plenty of my kids don't think I'm funny either. I do tell the same jokes to my nurses and my kids. So maybe, heaven forbid, it's that my jokes aren't funny.
A lot of people comment to agree to the comment, and then they said watching you do surgery is always amazing. It's like no bleeding, but when I do the same, white bleeding everywhere. And you got a follow-up question about how do you avoid damaging the facial nerve while you're strapping inside the bulla?
So the bulla, the facial nerve is not going to get damaged when I'm inside the bulla. The time that's going to get damaged is on my way into the bulla, when I'm retracting and dissecting. So I can see that I've got a bit more stuff up here cranially. It's always the hardest part to get to. And then we also have to avoid the dorsal aspect to avoid vestibular apparatus damage. Can I get some? Do you have flush already?
Flush ready.
Go ahead and flush in here. Go ahead. Can we get some bupivacaine, please? That's great, thank you. You still see a bit more secretory material down here. Can I get the flush, please? Can I get a neuro tip, please? Just have a bit more debris. Oh, got it. The big chunk that just came out. So there's a question about whether we have cat patients. We have many more dogs as patients in Australia than we do cats, because cats are often, so in contrast to America where I was about 50-50, in Australia, cats are not as popular here. And partly because they do a lot of damage to native wildlife. And so I probably do about 10-to-1 dog surgeries compared to cat surgeries. Is my head in the way?
Yes.
Still?
Still? Yep.
Yep. Sorry, guys. I'll get my head out of the way in just a second. I've got another big chunk of stuff down here. I'm just going to move the camera to the other side. That's your hand there. Yeah, sorry about my big head. I am a surgeon, and so I think it's a requirement to have a big head. Let's make it a mosquito hemostat, please. Thank you. Yeah, unfortunately, the best view for you guys is also the best view for me. So I've got to make absolutely sure I've taken out, look at that I could have left in there inadvertently. So you've really got to take your time and make sure that you get everything out. And it can be a real challenge when, for example, if they're bleeding,
Got a follow-up question.
yeah?
How do you prevent a complication with trigeminal nerve?
So trigeminal nerve really doesn't come into play here. We don't come anywhere near the trigeminal nerve with a total ear canal ablation, to my knowledge. It's more facial nerve, vestibular nerve, sympathetic trunk. Alright, so I'm pretty happy with that. Just do another flush. Yep. That's great, thank you. Okay, and we'll get our bupivacaine. So try to avoid the facial nerve. Can I get some 2O PDS, please?
The facial nerve is here.
Yeah, right in there and there. Thank you. Yeah, everything looks great. The radiographs, everything is healed beautifully and ready to go.
All right, so return in, like wait 2 more weeks and then return to normal activity? Or?
Yeah, just kind of gradual over the next few weeks.
Okay.
Thank you. I saw something very funny and very rude yesterday, which was a meme that in Australia, I don't know if in America or other countries, but you have 2 buttons on the toilet, one for partial and one for complete flush. And if you push them both together, it takes a screenshot of your poo. Yeah, that is very classic dad humor.
Yeah, take some time to process.
Sorry about that, guys. I'm actually apologizing to the viewers.
Yeah, we will see how people speak on it.
See what they say.
I have to go back and edit that out. I think I just lost 10,000 subscribers.
I think it's fine, yeah.
People are finding it fun.
Yeah, finding his area is pretty good. One comment said, not a dead yet, so I left anyway.
What's that?
It's not a dead yet.
My poor children. Let's see what this will look like when we pull that apart. Yeah. Is the aircon on? What we'll do is we need to pull that apart.
Put it back.
Yeah. You know, can I get some 2O something on a cutter? Get through that cartilage. Monosin is fine. Or is that on a monocryl? Is that on the taper?
Yeah.
What do we have on the cutter over there?
We have 4 iron.
That's probably too small. 3O. That's right. I'll keep going with this. Let's see if we've got anything next door, or...
Yeah, sure.
Thanks. Really shaking from my Sudafed that I've taken. Just anything absorbable, so monosin or PDS on a cutter.
We got a question. Have you had any complications from TECA surgeries?
Yes. So question is, have I had any complications from TECA surgeries? I've had lots of complications from TECA surgeries, the most common being facial nerve palsy. We see that temporarily in about 50% of cases. Temporarily in about 10% of permanently in about 10% of cases. I've seen vestibular signs probably in 1 to 2% of cases. I've seen draining tracts in about 1 to 2% of cases. Hemorrhage, moderate hemorrhage in about 10% of cases. I'll do the PDS, please. And severe hemorrhage probably in about 2% of cases. I've never lost a patient, touch wood, from hemorrhage during a TECA. I've never had to give a blood transfusion, but I have had some that lose, 20% of their blood volume, something like that. Flip that inside out if we can. And then we also see incisional infections as well in a moderate percentage of cases. All right, are you happy to finish that off? Yeah, yeah. All right, guys, so I'm going to leave you in Cynthia's capable hands, Cindy's capable hands. And there's a question about how I manage the complications. Actually, I'll take the camera off, Cindy, and I can talk to you in person because you don't get to see me very often. Just a second. And here I am. All right, so regarding managing the complications that we talked about, specifically facial nerve palsy. So with facial nerve palsy, basically what we want to do is just make sure that we keep the eye lubricated. So we're going to put artificial tears or ointment until either the facial nerve returns or we are confident that the retractobulbar muscle is taking over the function of the blinking. Regarding vestibular signs, the rare situation that we do see them, we will just manage the nausea with things like ondansetron or something like that. Regarding Horner syndrome that we see infrequently, that really doesn't require any management. For abscesses or draining tracts, we have to image them and then go back in surgically and find the residual tissue that we've left behind. Incisional infections, we're just going to treat them with antibiotics like we normally do. There's a question about can we leave antibiotic beads in case of bone lysis. I don't normally do that. I find that once you remove all the infected tissue and the lining of the bulla, that those infections tend to resolve. And so there's a comment that a lot of pugs have osteomyelitis in the bulla, which is fair enough, and they can fistulate, but the fistula is probably not from the osteomyelitis in the bulla itself. It's from leaving secretory tissue in there, so soft tissue in there, and that's the key with preventing the draining tract formation. I'm going to go ahead and wrap up the live stream now. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. And I'm not going to be live streaming anything else today, but hopefully tomorrow we'll have something to stream. Thanks a lot for watching. We'll see you again soon.